Thanks, Tanya. So today's topic is C. diff infection, which is a very, very serious issue that has picked up steam over the past few years. But an interesting piece of information, I ran across this in Netherlands, in Amsterdam, actually. They had a trained beagle in the name of Cliff. And what that dog did is they had the dog walk around the hospital and sniff out patients who have C. diff and would sit next to the bed. And they actually did a study comparing the cases the dog picked up versus the cases diagnosed by PCR laboratory, and they were awfully close. So I guess when we walk in the hall and we smell the patient's room and say if someone has C. diff, there's an element to that. I believe if you multiply that to 100 more times with the sensation that the dog possesses in smelling, it may help us. I just found out that that would be interesting. So C. difficile infection, the way it works is that you just need to be inoculated with 10 spores. So what spores are, the bacteria forms a shield, and that shield makes it hard to destroy. So what ends up happening, let's say you make contact with a person who has C. diff, and then you don't wash your hands, you get contaminated, you get the Clostridium difficile spores and vegetative cells, they get ingested. So the vegetative cells get destroyed typically by the acid, but the spores survive. And they travel through your small bowel, and somewhere in the distal small bowel, they start to vegetate. It has to do with changes in pH and acid and exposure to bile acids. And then once they become vegetative cells, they multiply and they start to produce toxins and they infect the colon. So that's just a cartoon to summarize that. So what is C. diff? It's the most common nosocomial infection in the GI tract. Spore forming, which makes it difficult to get rid of. It's an anaerobic gram-positive bacilli. Epidemics have been recorded in hospitals or hospital settings like nursing homes, dialysis centers, cancer infusion centers or treatment centers. It's on the rise in Canada and in the United States, causing increased morbidity or mortality. Clinical presentation, most common cases present watery diarrhea, crampy abdominal pain, but could also have bloody stools, abdominal distension, associated ileus, which we'll get into. Estimated $1 to $3 billion in excess medical costs, so that costs the hospitals a lot of money. Estimated 500,000 to 1 million cases per year, about 100,000 recurrences per year, an estimated 30,000 deaths related to C. diff-related complications. Why is C. diff infection increasing? Many episodes are due to, there is this new strain, NAPI-B1. So as you know, it's an ongoing evolution. We discover antibiotics, we throw antibiotics at bacteria, and then bacteria kind of accommodates and mutate, and they come right back at us. So this strain, what it does is it produces a binary toxin similar to iodotoxin and C. perfringens, which is another toxic C. diff bacteria. But the most important aspect of this strain is that the genetics are altered in the sense that it allows increased production of toxins. So if your typical C. diff produces X amount of toxin, this one produces way more, so it makes it more toxic. It has already acquired quinolone resistance, so like moxifloxacin, Cipro, gadafloxacin cannot really alter this bacteria. So you see it in areas or hospitals where we use a lot of moxifloxacins, because since it's resistant, that's probably the most common strain that's going to outbreak in that situation. So how is C. diff? How did C. diff get to this point? So there's a strong association between Clostridium difficile infection and antibiotic therapy. So the whole idea is sporadic and community-based cases are on the rise. The organism causes disease by producing two toxins. They damage the colonic mucosa, alter the chloride and water channels, and that's why you have diarrhea. So those toxins are enterotoxin A and cytotoxin B. A topic I'm going to come back to is the carrier status. Some people have carrier status for C. diff in the sense that when you test them for C. diff, they test positive, but they don't have any symptoms. So the theory is it's actually resistance. So they get C. diff, they develop resistance to it, and they do that by producing immune response. So some recent studies suggest that the body's immune response of some individuals may determine who develops diarrhea and who becomes a carrier. So it's estimated to be 15% of adults walking around healthy, no issues, but they're carriers to Clostridium difficile. And it's thought to be due to the body's production of immunoglobulin against toxin A. So the bacteria is there, it can produce all the toxins it wants, but the immunoglobulin is going to neutralize it, so there is really no infection or clinical sequelae. So I'm going to go over some IDSA guidelines regarding prevention and control, because I think this is really important. Being in a hospital setting, we want to minimize the spread of this bug. So I'm just going to go over them. So patients with C. diff infection must be accommodated in a private room with a dedicated toilet. You want to decrease the transmission that way. If there is a limited number of private single rooms, prioritize patients with stool incontinence in placement of private rooms. So if you have a patient, who has heart attack or a PE, but doesn't have loose stool, maybe doesn't need to be in a private room. But if a patient in the history, when you admit them, mention some loose stool component and we have private rooms available, it might be a good idea placing them in that room until we figure out what's going on with them. All healthcare personnel, and this is really crucial, all healthcare personnel must use gloves and gowns on entry to a patient with suspected or established C. diff. So I can't emphasize the importance of that. Sometimes, everybody's guilty, myself included. You say, you know what, I didn't touch anybody. You just kind of stick your head in the room, talk to the patient, and walk out. You still have to comply with these contact precautions. Patients with suspected C. diff infection, so if they have new onset diarrhea, abdominal cramps, positive risk factors, which I'll go over in a bit, should be placed in preemptive contact precaution pending the test results to come back. And we would typically, the IDSA recommends continuation of contact precautions for at least 48 hours after the diarrhea has resolved. So let's say someone has C. diff, you treated them, it's treated, they feel well. You don't stop at the moment they feel well. You want to give them 48 hours. And the whole idea is the spores can last up to that long outside. So, but depending on the policy of the institution, sometimes we keep them in contact precautions until they're discharged. In those patients with established C. diff infection, prolonged contact isolation until discharge, which I just mentioned. So, hand hygiene before and after contact the patient with C. diff infection after removing the gloves with soap and water. It's shown to be more effective than using those sterilizers or the sanitizers on the wall. Encourage patients, so don't tell the patient to just stay in bed. Encourage them to wash their hands and also shower, because showering and good hygiene of the patient is going to get rid of the spores on the skin. Use disposable patient equipment. So if we're doing a case or a procedure and we have an option of using a disposable equipment as opposed to ones that we autoclave, preference is to disposable patient equipment in that situation. Terminal room cleaning with sporicidal agent should be used in conjunction with other measures to prevent C. diff infection in high endemic rates and outbreak areas. Daily cleaning with sporicidal agents should be considered in conjunction with other measures to prevent C. diff infection and in hyperendemic settings. So cancer center, dialysis center, those areas, it's suggested that you use that on a regular basis. So how is the C. diff diagnosed? So it should be, clinical evaluation is the most important part. If someone doesn't have diarrhea, they test positive for C. diff, I don't really take that seriously. Clinical picture is really important, so it should be suspected in anyone who develops diarrhea in the context of antibiotic use. So your typical healthy patient goes to the dentist and gets an antibiotic for 5 days and then develops diarrhea afterwards. Or someone who develops a cold and sees their primary care provider and then they come back and they have diarrhea. That's the most common context. So something to keep in mind, the diarrhea can happen up to 2 months after the antibiotic use. So it's important to ask that in the history. So maybe the patient is not going to remember, but if you just keep at it, they'll say, oh, wait a minute, yes, you're right, 2 months ago I did take antibiotics. And that will actually direct us towards the course of action. So there is also some case reports for the surgeons out there. Pre-op antibiotics, which we give routinely before incisions, there are cases relating to administration of cephalosporins. So that's also important to inquire about patients who had recent surgery and had prophylactic antibiotics. So the diagnosis is made, there's 2 ways to diagnose it. The older test is the enzyme immunoassay, EIA test, which detects the toxin in the stool. But now it's rapidly replaced by PCR, which polymerase chain reaction of the bacteria in the stool. Some advocate for both tests. This is because if someone has a positive PCR, but they're a carrier, and they're not really, they suggest that in order for you to treat them, test for the enzyme immunoassay, and if that's negative, then you don't need to treat them because they're not really producing the toxin. That's the thought process. I don't know how efficient in that cost-wise, but it's something to think about. Now, some strains, as I touched on earlier, produce mutant toxin A, which makes it difficult to use the EIA testing, the immunoassay testing that I mentioned earlier. So always maintain a high index of suspicion. If the test comes back negative and the patient has those risk factors, I would still treat. PCR for toxin B is the best available test right now. It has a higher sensitivity. When in doubt, empiric therapy is appropriate. So if you think someone has C. diff, treat them. But that could also be a problem because there's a lot of patients that have diarrhea for other causes, like irritable bowel syndrome is a very common thing. And I get a lot of patients in the clinic and they say, Doc, I've had diarrhea for 20 years. My PCP found a positive C. diff and I'm on the 4th cycle of antibiotics and nothing has changed. It's hard and it could be tricky at times, and distinguishing true C. diff infection from other causes is really, really important. Now, white blood cell in the stool, that's pretty much gone. It used to be used back in the day, but it's not really a reliable indicator of C. diff colitis. There was one study in the literature that looked at patients who had C. diff, confirmed C. diff cases by PCR, and they had absence of white blood cells in the stool, up to 72% of them. So it's a useless test pretty much in that context. So the treatment of C. diff, I'm going to go more into depth, but there is a bunch of guidelines out there. There is the IDSA guidelines, there's the ACG guidelines, which I like to use, being a gastroenterologist myself. But at the end of the day, common sense prevails and clinical judgment prevails. Guidelines are there just to guide us. But currently, the most used antibiotics are Flagyl and vancomycin. But one thing is standard throughout. It has to be 10 days, not 5 days, not 7 days, not 2 weeks, not 3 weeks. 10 days is the standard treatment. So that way we minimize overexposure. There's a third antibiotic, fidaxomicin, or Difficile is the other name for it. It was approved a few years ago for the treatment of C. diff. Initial reports did show similar efficacy to vancomycin, and it's used to mild to moderate infections, but it can be very expensive, and I think my colleague Danny is going to touch on that. The recommended doses for mild to moderate infections, so Flagyl or metronidazole, you can do 250 4 times a day for 10 days, or you can do 500 3 times a day for 10 days, or you can do vancomycin 4 times a day for 10 days. And I'll go over when to start which one. So which drug is better? So there is actually data out there. So the 2 drugs are equally effective for mild disease. And I should have made this bold. Not for severe, not for moderate, not for mild to moderate. Mild disease, regular, standard case, both medications can be equally effective. So there's a study that looked at vancomycin and metronidazole in mild to moderate disease. The response rate for vancomycin was 98% and 90% for metronidazole. Both numbers are pretty good. But patients who have severe disease, data show that vancomycin response were 97%, but Flagyl drops to the 70s, so that's not very good. Another very important thing that I cannot emphasize enough, do not give anti-diarrhea medications to C. diff infection patients, because this will lead to trouble. It will lead to perforation, sepsis, complications. So things like Imodium, Lomotil, stuff like that, try to stay away from that. There is no role for probiotics in first-time infection or severe C. diff infection. There is other roles for recurrence, which I'll go over in a second. So what are the ACG guidelines, or the American College of Gastroenterology guidelines regarding C. diff treatment? So what I would do is, when I encounter a patient with C. diff, I risk stratify them. Is this mild, severe, severe and complicated, or somewhere in the middle? So mild disease, I would typically give Flagyl the first time. Severe disease is defined in a patient with C. diff infection who has low albumin, less than 3 grams, white cell count more than 15,000, abdominal distension. And these patients, initial therapy should always be vancomycin, because Flagyl is not going to be very effective. Severe and complicated disease. So those are patients who have severe C. diff with complications such as pseudomembrane zonal colonoscopy, colonic wall thickening on the CT scan, ascites, hemodynamic instability, high white blood cell count, increased creatinine and renal function, mental status changes. All these patients need to start on high-dose vancomycin, 500 QID and IV Flagyl if they're hospitalized, or I assume these patients would be hospitalized. You need that combination for them. There is no role for IV vancomycin, as it will not penetrate the colon. And then vancomycin enema can be used in patients with severe disease who have ileus. So this is just some examples. The arrows tell you the colonic thickening someone can develop on the CT scan, and this is pseudomembranous colitis. We see that in the colonoscopy, and it's pathognomonic for C. diff infection. And at that point, they're severe and complicated. So more on the severe and complicated patient. It's really important to continue serial clinical evaluations just to see if they change throughout the day. Do they develop peritonitis, sepsis, perforation, bleeding? Early surgical consultation is essential. The last thing you want to do is you want to wait till the last minute until they perforate, and then you call the surgeon, because you're not going to have a happy surgeon if you do that. But involving them early on is really important, because that way they're prepared. They can take the patient to the OR when needed. So severe and complicated, some criteria which I mentioned earlier: leukocytosis, lactate more than 5, serum creatinine, especially in patients over the age of 75 years of age. If it goes up, they're at increased risk of death. Once surgery is done, typically they do a total colectomy with ileostomy. Sometimes, depending on the patient, they preserve the colon and they just do a diverting loop ileostomy. And mortality from fulminant toxic colitis that requires colectomy. So if it gets to that point, mortality, you're looking at 10 to 40%. So you never should get to that point. You should try to anticipate things earlier. There are small studies that looked at adjunct therapy for severe C. diff infection with IVIG that made the news a few years ago, and steroids, but not enough data. So the data is conflicting on that. This is toxic megacolon of a real colon. That's what it can look like. So back to the carrier of C. diff infection. So very common in infants less than 12 months of age, 80%. If you have an infant less than 12 months, so my son, for example, if I test him for C. diff, 80% chance he'll test positive for C. diff. But it's just a carrier status. As they get older, as the microbiota develops in their digestive system, it decreases once they get more than 2 years of age. So in children greater than 2 years of age, if you suspect C. diff, go ahead and test for it, especially in the context of inflammatory bowel disease or if they're immunocompromised. In adults, 5 to 15% are carriers of C. diff. Treatment of asymptomatic patients or patients who have diarrhea from other causes is not indicated. Sometimes it's difficult to distinguish carrier with other causes of diarrhea or from true C. diff diarrhea. So seeking expert consultation, would be a good idea as opposed to just throwing antibiotics at them. 20% of patients who have C. diff, it's estimated that will recur. So the recurrence of C. diff is defined as C. diff infection episode within 12 weeks. So that's 3 months from a prior episode. Pathology is largely related to colonic microbiota with much less diverse flora in their colon, and that's because it could be that's the way they made up, or it could be exposure to antibiotics. Impaired immune response, so in patients who have cancer, autoimmune disease, those ones who are on steroids, COPD, emphysema, asthma, radiation, inflammatory bowel disease are also contributing risk factors for recurrence. Other risk factors include older age, they're more likely to recur, intercurrent antibiotics use, so if someone has osteomyelitis and needs to be on chronic antibiotics, that's a risk factor. Renal disease, prior C. diff recurrences, and recurrence can occur as early as 5 days after stopping antibiotics or as late as 60 days after stopping antibiotics. So always have a high degree of suspicion. So the treatment of recurrent C. diff infection. So following the second recurrence, so if they recur for the first time, I would use that criteria: mild to severe, severe and complicated, and treat. So if they recur again, they come back to you and they're mild, there is no issues, you could consider a flagyl, or you can do vancomycin depending on their risk factors. But the second recurrence, if they come back, so this means it's their third time acquiring C. diff, the evidence favors pulse taper of vancomycin. So we would start with 125 QID with a taper over several weeks. Flagyl taper has been looked at. It's less effective, but it's something you may consider in someone who vancomycin is contraindicated or cannot afford it or that sort of thing. Fidaxomicin for recurrent C. diff, studies showed fewer recurrences when compared with vancomycin. So if you have a patient with C. diff, you give them Fidox versus Vanco, they had fewer recurrence, but they still need more evidence regarding effectiveness of it, meaning is it really truly effective or is it not? We still don't know. Probiotics, so Saccharomyces boulardii, that's a probiotic shown in a placebo-controlled trial as an adjunct to antibiotic therapy for recurrent C. diff only. So someone with recurrent C. diff, they gave them this probiotic with the antibiotic, and it did show efficacy of up to 50%. But then future trials looked at the dosage of vancomycin and the duration, did not really show much effect. There was no evidence for lactobacillus. Complications, so probiotics do cause complications, especially in immunocompromised patients or patients who have severe colonic disease. So things to keep in mind: bacteremia, liver abscess are associated with lactobacillus, fungemia with Saccharomyces. Probiotics should not be given to patients who are immunosuppressed. So this is something that we have to keep in mind. Also, there is new therapies or therapies that have been looked at, uses the immune approach. So patients who have recurrent C. diff have been tried with IV, immunoglobulin, IVIG. Recent systemic review concluded that the evidence for its efficacy is weak, and it's currently not recommended. It can lead to aseptic meningitis. There has been much interest in a monoclonal antibody to toxin A and B used as an adjunct to antibiotics in patients with recurrent C. diff infection. It's currently in trials. So some stuff is coming down the pipe. Fecal transplant, which is really the big thing now. So the whole idea is taking stool from a healthy individual and giving it to a person with C. diff infection. And the whole idea is you're altering the colonic microbiome. So the first date of this, it was done in the 50s. Someone had pseudomembranous enterocolitis, and then they responded. So that's the first reported case. But the first actual recent treatment was a 1983 65-year-old woman whose recurrence resolved. Cases have been administered, so you can do this by NG tube. I don't see why would anyone want that, but you can do it that way. You can do an upper endoscopy, you can do a colonoscopy. That's the preferred way, and that's how we do it here. I usually do a colonoscopy, and I inject the material into their colon. Retention enemas are used also. So if you have a frail patient and they're 90, in their 90s, and they can't undergo any procedure, you can try a retention enema. There is evidence for it. Overall, the evidence is 89% cure rate, which is really excellent. It might cause IBD patients to flare, so we have to be careful in patients who have already colonic infection or colonic issues. It's important to ensure that patient has an actual C. diff recurrence and not a carrier of C. diff, as we touched on before. Sometimes patients who have C. diff, their symptoms resolve, but then after that they develop diarrhea, and that is called post-infectious IBS. So it's really important to make sure it's not that, and we don't treat them for that with fecal transplant. So the sources of the stool, it could be patient-identified individuals, like a relative or a friend. Currently, we obtain our samples from the institution, and there's a preparation protocol that we use. All donors must be screened for GI symptoms, because the last thing you want to do is to give them C. diff if they didn't have it. Have blood, make sure they don't have blood in the stool. Fresh and frozen stools seem to be equally effective as oral capsules. The only issue with oral capsules is there's some degradation issue in the stomach and acidity and that sort of thing. So some recent data show it's less effective. Stool samples can be delivered, as I mentioned, NG tube, enema, colonoscopy. So the colonoscopy route allows visualization to where we're injecting the sample. Enemas might be a good option, as I mentioned, in a frail patient who can't undergo any procedures. And those patients who fail multiple fecal transplant need to be on frequent courses of antibiotics. So this is the most difficult C. diff patient you'll encounter. They fail antibiotics, they fail pulse therapy, they fail fecal transplant, and they show up to you again. And those patients, we just have to cycle antibiotics with them, unfortunately. There is no other way to get rid of this. So some data for fecal transplant. So there's a multi-central trial, 77 patients who received fecal transplant, were followed for 3 months to a number of years, showed 91% primary cure rate and 98% secondary cure rate, and no long-term adverse effects. Although 4 patients did develop immune disease subsequently, whether it's related to the fecal transplant or not, we don't know. There is a theory that inflammatory bowel disease, one of the pathogenesis of it could be alterations in the microflora. Fecal microbiota transplant is recommended after a second or third recurrence, and strong emerging evidence for ill patients who are not responding to medical therapy and are too sick to go for surgery. So the patients I mentioned earlier with colonic thickening, borderline toxic megacolon, the surgeon comes and says, listen, this is a 95-year-old gentleman, won't survive the OR. There is actual role to do a stool transplant in those patients. There's a series of 57 cases of severe or severe to complicated C. diff infection treated at one center by serial fecal transplant administration, showed overall efficacy of 91% and a 3-month survival of 78%. So that's pretty remarkable, I think. What's in the pipeline for C. diff? There are several products. One is called ridinilazole, which is a narrow-spectrum antibiotic of preserving bacterial gut microbes. So it has some sort of a probiotic component to it. There is a medicine called kedazolid. It's another experimental antibiotic which recently failed to show efficacy. For the prevention of C. diff infection, there are 3 vaccines in development. So maybe down the road, a vaccine will be developed. There is an enzyme that degrades beta-lactam antibiotics in the gut. So those are for patients who need to be on antibiotics for whatever reason. And it makes sure that once the antibiotic gets to the gut, it's degraded. It's another way of tackling the resistance to antibiotics and the alteration in the microbiome. There are several microbial-based products in trials to treat recurrent C. diff infection. I think that concludes my part. We'll have Danny come and do his talk, and then we'll take questions. Yes, so this video, I think everybody should watch, myself included.
Do not confuse any lightheartedness in the following video with a glib attitude toward the problem at hand. The makers of this video are very serious about the prevention of hospital infections. Another busy day. Traffic as usual. Now look at that. He goes right past the hand gel. Doctor!
How's the light today?
Come on, pain dog.
Still a little better. All right.
Not even in gloves? Oh, come on. That doesn't really happen, does it? If you could see what I see. MRSA, VRE, Pseudomonas, etc., etc. Your attending isn't wearing gloves, so you're not either, right? Wait, the hand gel.
What? Okay, yes.
Are those gram negatives or gram positives? Oh,
How can I help you?
those microbes spread everywhere.
Yes, I am. Okay, I'll draw that blood right now.
MRSA, VRE, whatever. Good grief. Nurse, you didn't clean your hands either? Oh, man. He just had an operation, and you put a big IV in his neck. It goes almost all the way to his heart. Please don't! Finally, that's the part I wanted to see. Clean your hands before and after every time you contact the patient or the patient's environment. If your hands are not visibly soiled and the patient doesn't have C-Diff, use alcohol-based hand gel to kill those germs. See? Doesn't slow you down. Really, you should also clean your equipment just as often. Your patients thank you.